Amazing. Good. So, good afternoon again. Sorry, as I was chatting with Eve for a day that I'm sure many of you know, and you probably know that Marion Busenmarker and Jack Shalkin discovered, so to speak, the PCA-free test. But Eve, the person that was talking here, is actually the second co-discoverer of the PCA-free test. We didn't talk about that, but... So, after the truly great talk by Sigrid about screening, we're going to try to kind of uncouple screening with active surveillance. And first question, are there people in the audience where you have patients who are eligible for active surveillance who would not offer it? Does that happen? So, basically, everybody, when you have a patient who is potentially an active surveillance patient, will offer. It's a great, great thing. So we do know that there's a much greater recognition of the overtreatment. We discussed that with Sigrid, and the concept has gained traction. We also know that any time when you have an active surveillance policy and management, there's a risk of having high-grade prostate cancer hiding somewhere in the prostate. We now know that many germline variant, mismatch repair genes, BRCA, and others are important players that place patients at increased risk of having, at one point, high-grade disease. And I think that what we are currently struggling, and we'll see how we can manage those patients together, what to do with a patient who is an active surveillance patient, where all the biopsies, everything shows active surveillance, but he does have a risk, whether it's germline or another familial risk. We also know that the PSA kinetics, which is the PSA doubling time or whatever you use, is actually a pathetic, I use the word on purpose, a pathetic marker to trigger when to decide on action or therapy. We now have the new kid on the block, which is multiparametric MRI. We have new tissue and serum markers. And we finally have randomized data. So until now, we could talk about active surveillance, long-term, blah, 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 but we didn't have any randomized study, and we finally can share together some of the randomized studies. We have long follow-up, and believe it or not, we actually have close to 2,000 publications on the topic. So a lot of data. Now, there are many guidelines on the active surveillance. We use in Canada, basically in Ontario, the Cancer Care Ontario guidelines, but by far and large, the same kind of patients are included. What are the current unmet needs? Busy slide, because I didn't want to have 25 slides describing that. 1, what are the molecular events that signal the progression of low-grade disease to something more aggressive? 2, how do we integrate the role of germline variants in the active surveillance paradigm? 3, how do we identify the wolves in sheep's clothes? Everything looks like an active surveillance patient, but actually there's something more sinister hiding there. 4, how do we integrate the MRI and biomarkers into the daily management? Are there intermediate risk patients that actually are candidates for surveillance? Are there interventions, whether diet, pharmacology, or you name it, that may actually mitigate the risk of progression? And what is the most effective, efficient, and cost-effective way to follow our patients? And finally, is there a risk stratification? What we know is that virtually no documented Gleason 6 prostate cancer will metastasize. That's a great study by Ross, and there was another paper by Scott Egner. When you re-review the patients who progress, none of them is actually a true Gleason 6. So By far and large, there's no Gleason 6 self-progression. I know, you know, I'm sure the GSA, Journal of Clinical Investigation paper, where they took one patient and where the metastatic clone came from a Gleason 6 subclone, and they proved it, they reviewed it. I have I do remember as yesterday a patient who had Gleason 6 prostate cancer. Everything was reviewed and presented with metastatic disease. But that's one, and we see, honestly, like you, thousands and thousands. So I don't say it never will happen, but it's such a rare event that it's probably about the same as winning at the lottery. Unlikely. So if Gleason 6 or pattern 3 doesn't metastasize, why does volume of Gleason matter? And these slides, this particular slide was a courtesy of my good friend Laurie Klotz, who would have been equally, if not even better, to give this course here. Well, the answer is that high volume is a surrogate for the presence of higher grade cancer. So by itself, Gleason 6 is Gleason 6, but when you have a high volume, it's likely that it's going to be some instability. You can have a misclassification, but you can, and that's debatable. Are there any pathologists in the audience? No. Theo van der Kwast, who is from Rotterdam originally and who moved, thanks, to Toronto about 13 years ago, is our world-class pathologist. And Theo keeps telling us, and he really believes that there is over time roughly a 1% progression over the years. And that gets back to the question of the person with the Gleason 6 that we discussed, who is now 90. There's a 30-year lifespan, and if what he thinks is true, it could address some of the question, why is it what we see Gleason 6 at one point? We follow those patients at one point, you really have a higher Gleason. Completely unproven, absolute hypothesis. The first thing, we need to select the patient and the right patient. And there are many, many criteria. The Johns Hopkins, the Sunnybrook in Toronto, the Göteborg, the Royal Marsden, the Australian, the Price. What you see is that by far and large, most of them accept only Gleason 6. Very few accept a little bit of pattern 4. Most will require less than 50% of the core with the tumor. The PSA in most of the series, but not all of them, will have to be less than 10. And that's one of the characteristics of the Price, the international study, and that goes along the Stockholm and the role of the density. More and more people think that you can't have patients into your active surveillance without balancing your PSA level with the size of the prostate. A PSA of 4 in someone whose prostate is 18 grams is completely different, of course, from a PSA of 4 in someone whose prostate is 90 grams. And that's why the Price and the International have decided to include the PSA density, for what it's worth, as one of the criteria. Laurie, who is somehow with Peter Albertson, as you know, the father of active surveillance, initially had included absolutely all the favorable risk, up to 15 of PSA. So some of the data that I will present actually include patients who had PSA as high as 15, and some of the Gleason 3 plus 4. However, since a long time, he realized that maybe including some of these PSA of 15 and including some of these pattern 4 were a little bit dangerous, and he has restricted, and most of us have restricted, to truly favorable risk patients. At Toronto UHN, a little bit south of Sunnybrook, we limit our patients to PSA less than 10, clinical stage T1, but even T2 and T2A, absolutely no Gleason grade 4 or 5, less than 3 cores, although I have to admit I'm a bad guy. I actually usually go even up to 50%, and no more than 50% in the core at the initial diagnostic biopsy. And all patients have to have repeat biopsy. Now, one of the things, and whenever we have fellows and residents, that I stress, if you just look at the final pathology and you decide on your active surveillance criteria, often you and me will get into trouble. When you have, and especially when you take the 50% involvement, you also have to look at the length of the core. The devil is in the detail. If you don't take the time to go core by core, and if you don't realize, for instance, that it's 60% of core number 8, but core number 8 was 1.1 centimeter, by definition, yes, because your core should be at least, 1.5, 1.8 to 2.2 centimeter. And so it's a matter of volume. And this is a surrogate for the volume, but that means that you can't do the perfect job if you don't put everything all together and only take the conclusion.
The length of your course at the center, the length of your course, which length do you use? 18?
Yeah, 18 to 22 usually.
Usually 18 to 22.
Yeah.
But it's not necessary. Only with 15 is great.
Yeah, no, I hear you, and again, I completely hear you. I think one point is to get a diagnosis, and what you get from the diagnosis will the length of the core. The other is how much of the core involvement is safe enough to move for active surveillance. And because we all say that it's a matter of volume, if you have more than 50% of a core, which is 2 centimeters, by definition, this lesion is more than 1 centimeter. And if you have 1.2, 1.3 centimeter in the core, and then you're told there's 60, 2 seconds, you're 60, although you think that it fulfills the criteria, in terms of true volume, it doesn't.
In your institution, do you have any production protocol to compare the target biopsies? Because then you have more positive.
It's a great question, and I'm struggling like you.
What is the question?
The question,
Repeat.
no, sorry, no. The question was, more and more nowadays, we have an MRI, we follow those patients, and then you're going to have a biopsy of the target, correct? That biopsy of the target, really often, first of all, it has to be to a certain size, because otherwise it wouldn't be picked up by the MRI. So it's going to be about 1 centimeter no matter what. Then you do the biopsy. Then you find 1 centimeter. And the question is, how do you now interpret those criteria at the time when we do targeted biopsies based on studies that were using the classical criteria? I will tell you how personally we do it. We often have additional markers on the tissue, and we'll go through it. So we not only take the size, the lesion, but we now use often the cipher, and others to really characterize. That's usually the way. So as I said, the PRIAS, the Prostate Cancer Research International active surveillance study, has included the PSA density 0.2. And the big question is, if you're more stringent in your criteria, you accept only 2 cores, or you accept only PSA less than 10, or you kick out all the patients who have a positive DRE, does that translate into better outcomes for the patient? And that was one of the studies that my buddy Tony Finelli and Maria Mizarenko did. They took all the men that were in our active surveillance program in Toronto, and we have actually now, honestly, about 1,500 now. And they used and modeled absolutely all the entry criteria: Price, Johns Hopkins, Miami, California, MSK, UFT Sunnybrook, Royal Marsden. And they looked basically as whether one was better than the other in terms of inclusion protocols. And the results were that there were some patients that would have been excluded from active surveillance were you to use more stringent, especially the Johns Hopkins, which is really stringent. But there was absolutely no difference in PSA velocity. There were no difference in terms of people who progressed. And the rate of biological progression was absolutely the same, whatever protocol you would have taken. And that's the intervention rate. Nothing really reached significance. And the conclusion was that we truly have the impression that even if you use much more stringent criteria, the only thing you do, you exclude patients who would have benefited from active surveillance rather than helping them. Probably the absolute truth lies in between, but I don't think that you absolutely need to take, whenever you choose a criteria for your active surveillance patients, you can be slightly more liberal. Nothing will happen, and we showed that. Now, second and big part nowadays, the role of genetics in selecting active surveillance. What we know is that BRCA germline mutation is an independent prognostic factor in prostate cancer survival. So the big question is, who can be managed by active surveillance? And to give credit who deserves credit, most of you are in the younger age group, but for some of us gray-haired, in 1995, for the first time, before BRCA was invented and discovered, a French group published in Science a paper. They were using only classical chromosomes. And on the chromosome X, they could actually see that there was something transmitted from the mom to the patient, but they had no clue that it would be the BRCA. And so the story about the passage of a risk factor from the mom to the siblings is actually already 25-year-old. Now, we know that BRCA tumors are different from the sporadic, clinically detected prostate cancer. And this is also a group with Rob Bristow now in Manchester, Paul Boutros with us, and where they clearly showed that when you have the same tumor but you have a BRCA mutation, the way that they behave has nothing to do with the classical Gleason 7. They behave more like a metastatic or a Gleason 8, 9, and 10. We also know that the mismatch repair genes, the DNA mutation, BRCA1, 2, ATM, and others, are also in association with metastatic prostate cancer. We even know from larger studies that mutations in ATM and BRCA distinguish those indolent prostate cancers from those who will be lethal at an early age. And so I think these studies clearly show that most of these carriers were in really high risk of dying. Again, we're not talking about 50%, 60%. It's 1% versus 6%. But 6% is fairly significant when you discuss. And that means that the big question that many people have now is whether patients who are absolute demonstrated BRCA carriers are even candidates for active surveillance, given that at the tissue level, their biology in terms of copy number alteration is very similar to the lethal one, and that their risk of dying is fourfold increase. And fourfold is way more, 6% is pretty significant. Do you guys offer active surveillance in a known BRCA patient? Have you had that experience? I think it's worth thinking. Now, you may or may not remember our group last year published a new area, which is not the calcrane 3, but it's related to the PSA, the same gene. It's a calcrane 6, and where we took part of the European randomized screening study of prostate cancer patients. We took the PLCO, the American study, and we took a Toronto group, about 2,000, and we showed that SNPs in the calcrane 6 are associated with a 4 to 5-fold increase in risk of Gleason 8, 9, and 10. We're validating this and larger. It was the first demonstration like the bracket at that time. But what I'm getting at is we're more and more fine-tuning a group of patients where they carry those germline variants, which are unlikely to have only indolent disease. When you look at the overall and cancer-specific survival, the median follow-up here is a little bit shorter, but what you see is that it's close to 100%, 99.7%. And I think we have to be fair. It's reasonable to say that in 2018, when we offer patients with the follow-up that we have on those patients, the survival rate is close. We will always miss the rabbits and the birds, like Sigrid talked about. We have to accept that. But overall, what we do is reasonably safe. Now, if you look at the outcome of the studies that have over 5 years of follow-up, and that's a 2010 to 2015, again, whether it's the Hopkins group, which uses very stringent, restrictive criteria for including patients, 15% prostate cancer-specific mortality, 0.1%, that's truly, truly low. Or the Sunnybrook that, I remind you, had included Gleason 7 with a 1.9% at 10 years. We can debate whether this is high or not. But I think we're approaching 99. I think it's reasonable to say that it's close to 99% at 10 or 15 years. Laurie published his first paper in 2010.
Alex, a question.
Sorry. Yeah. No, please.
What do you think of surveillance for low volume Gleason 7 3 plus 4? I know that there are some in the Toronto groups, but what do you really think of it nowadays?
So I'll answer indirectly first and quickly. When we did our autopsy paper in 2013, our JNCI large publication, where we looked at two populations without any PSA screening. We took Russians from Moscow, Caucasians, with the Epstein, there was no PSA screening. The weather is as cold as here in Canada. The food is by far probably similar, but that was our assumption. But there's no PSA screening. 25% of the cancer that were found were Gleason 7 and 4. So it means that 60% of men aged 60 had some occult prostate cancer, and 25% of the 60% had Gleason 7, which means that when you have a prevalence of 60 to 70%, a risk of being diagnosed nowadays of about 17%, and the risk of dying more in Sweden, 5%, but 2 to 3% in Europe. There is a huge disconnect between the pool of Gleason 7 and those who die. And that means indirectly that there is a subset of patients with Gleason 7 prostate cancer who will never be diagnosed with the disease and will never die. Our main struggle is that I don't think that anybody today has the tools to pinpoint, even molecularly, how these Gleason 7 behave, and to safely tell that you can or cannot include. And because everybody wants to err on side of caution, and because the data here, now I'm going to go here, from the Gleason 7 show that although the mortality of the long term is very good overall, there is a 2 to 3-fold increase in these Gleason 7, not at 10 years, but at 50 years. And that's why I do. So if the question is, do I include patients with Gleason 7 prostate cancer in active surveillance? The answer is absolutely. But what I tell those patients, I tell them that just about 2 kilometers north, Laurier grew the series and there's an increased risk. I tell them that we're not sure how to monitor and how to characterize, and that to a certain degree it's a shared decision and a shared risk. If patients are ready to take it and they understand, fine. If they don't, then well, that's a little bit the way.
Do you have an age cutoff for selecting patients with these symptoms for active surveillance? I can imagine younger men, 50 years old, or maybe less keen on selecting them for
Yes. Now, what we forget sometimes, there are a lot of patients who really want active surveillance no matter what. They're absolutely not interested in treatment. And so we forget about the 50-year-old gentleman who basically doesn't want to hear everything that he can that would please him, that there's a way to monitor. And that exists as well. I would tend to say that if I have a person of African Canadian or African American background, we are usually slightly more careful at proposing. It certainly agrees in 7 plus 4. That would be something where we're completely uncharted territory. Now, as I told you, Laurie published after his longer follow-up, and basically the survival is close to 98%. But what's interesting is really to see the threefold increase in cancer-specific survival of these Gleason 7. And that's why it's difficult to dismiss those data. The data are the data. And so it's difficult not to tell a patient that the few series we have show an increased risk. Not huge, but increase. And when you talk about interventions and reason for intervention, here in that study, most of the time it was a doubling time, which even there is not necessarily what we would consider as acceptable nowadays. So the summary of the Toronto Laurie's cohort with up to 20 years of follow-up is that there was a fifth of those patients that were intermediate risk, and that in those with Gleason 7 and PSA doubling time less than 3 years, usually this is not a great characteristics to follow those patients. That's the best I can help to say who are the patients that we could safely. Now, same thing happened with intermediate risk in Göteborg. This paper is already 5 years old, but what they did was they followed 1,000 patients and 400 were managed with active surveillance. And they did include, again, 20% of intermediate risk. No patient with Gleason 6 at diagnosis had died of prostate cancer. Among the men with low-risk disease, not single MET arises, which is the mirror answer saying that one has to accept that in the 22% of intermediate risk patient, some events will happen, and I'm not sure that anything can prevent it, to be honest. And that was summarized by Toshi, who is now back in Japan, in Tokyo, demonstrating who are the bad player. 30 of those 980 men in Toronto developed METs. 211 were classified as intermediate risk. And so we are basically cautious at proposing active surveillance and Gleason 7. There's certainly a subset of people who can be eligible. I do have a lot of those patients, but I'm not sure that we are able to really guide them easily. Now, if you look at the other large series from Hopkins, more stringent criteria, same thing, prostate cancer mortality close to insignificant at 15 years, so it's safe. But 0 patient with Gleason 7. And when you look at the other question, when patients are younger, does that change? Well, the group from Peter Carroll and Matt addressed that. They had 1,400 patients The median follow-up is a little bit short. It's about 4 years, so probably it's a little bit too short to have and to be able to draw conclusions. But what they showed is that there were no major differences whether you would start early or later. A little bit, but nothing really significant, and certainly no difference in terms of risk of progression or definitive treatment, which means that they showed in that study that the anxiety of starting early in young men is not supported by short to mid-term data. I still want to see their data in 15 years to be able to tell you it's completely safe. But even in the Göteborg, even in the RSPC, in the Toronto group, we have a significant amount of people who are less than 55. They have been followed for 10 to 15 years, and we haven't seen similarly major events. So I think by far and large, it must be safe. The big difference compared to the other years when we were doing this course is that we had no randomized study. Series, but that's about it. We now have randomized studies. We do have the 10-year outcome of the PROTECT, comparing active surveillance or whatever you name it for the active monitoring, surgery, and radiation. And what clearly showed up was that there were no difference whatsoever, as you remember, between the three arms, radiation, surgery, or monitoring. But the price to pay was that close to half of those patients in the active monitoring ended up being treated. So part of the 99+% of survival takes into account those patients who have been treated. It's an intent to treat, of course. But I think it would be a big mistake to say, we have 100 men, all of them will be alive at 15 years without treatment. That's absolutely not what we see. And then, of course, I don't think that you need to be a statistician, but you need to have good glasses to see any difference between the three. Just nothing happens. And even more interestingly, and I was kind of surprised myself, if you look at the Gleason 6 or 7, and you look at the number of people who died from the disease, there's actually no difference in between the 6 and 7. The numbers are so small that I'm told by Freddie and the others, you can't draw any conclusion. It's too small numbers. But the matter of fact is that there were some issues in Gleason 6 as well. We have more data. We have the PIVOT trial. Last year, mortality, no difference. So after 20 years of follow-up, despite all the drumming, the trumpeting, for patients with localized disease, surgery was not associated with lower all-cause of prostate cancer mortality. There were more side effects, of course, but no difference in survival. I know that. So can you guys tell me what has been the criticism of the PIVOT trial? What was the main criticism that anytime when you are in discussion, PIVOT, why do they say, They say, because it was an unusually morbid group. The mortality from the all-cause was close to 50% at 20 years, which means that I remember by name the people that died from unrelated causes when I operated the right prostatectomy. I can really remember this poor gentleman had a car accident. There's no way I remember that 50% of the men died from other causes. And that means that it's kind of really strange group. I don't know where my brother and they all found those patients. He says that everybody dies. And so that's why some people have said, difficult to really translate, but the matter of fact is from the PROTECT, no difference. From the PIVOT, no difference.
Trial at this conference presented yesterday by Firas Abdullah, where they've looked at multiple cohorts in the U.S. and just found that this population was older and sicker. So, makes sense.
And then finally, we even have randomized trials finally published comparing treatment with active surveillance. And that's, for instance, is a well-known study published in Lancet Oncology by the British group with Mark Emberton, where they compared photodynamic targeted therapy to active surveillance. It was an open-label randomized trial. 47 centers were involved in Europe, mainly low risk, with 206 treated by vascular photodynamic, 207 by active surveillance. Very short follow-up, 2 years. What appears here is that 58% of progression in the active surveillance versus 28 in the dynamic. Negative biopsies at 2 years, 49% when they re-biopsied per protocol versus 14%. So when you look at those data, they seem to suggest that if you treat what you see, the number of people who will progress or will have a positive biopsy will be decreased. At 2 years, it's absolutely ludicrous to think that you'll see any difference in prostate cancer death or anything. It's way too early. It's also interesting to see that for a randomized study, they managed actually to have 44% of pattern 4 in the active surveillance and 24% in the photodynamic. So my understanding limited of 200 men in each arm is that by far and large you should find something which is not so dramatically different and still has way more reason pattern form. Reason, I don't know. But when you have 24 versus 44, with what we know from the reason pattern form, it's not unexpected that there will be more progression. And so to what extent this is truly a treatment, I don't know. But it's worth looking at the data. Can we use safely 5-ARIs in patients with active surveillance? The answer is yes. Our own data show that. Neil did a superb randomized study where patients were randomized to dutasteride in a double fashion manner. No difference, no more high risk. And time per progression was exactly no different. And I didn't have the time to include it because it just appeared this week. A Swedish group in the GNCI, and maybe Sigrid could describe, they did also all their registry with active 5-alpha reductase inhibitor, didn't find anything. No more high grade, no more, and which means I think that it's reasonable to say that when you have a patient under active surveillance, you have a reason to give him a 5-alpha reductase inhibitor, whether he has symptoms, you name it. Nothing will show that he will have a much higher increased risk of high-grade disease. When to switch to definitive therapy? A lot of guidelines, but not a lot of agreement. Most of them say that when you have a higher volume of disease or an increase in your Gleason. One of the questions that we get all the time is the exit strategy safe? You have a patient, he's under active surveillance, and then you decide to treat. Don't we treat too late? It doesn't appear so. Here, Raj, who is now in Houston, did a study where he looked at all the data of patients that were treated up front versus patients that were managed first with active surveillance and then treated, and there was no difference. So I think it's reasonable to say that what we use as a criteria is safe enough not to end up with a lot of mets or adverse pathology. Monitoring is so difficult. I don't think that anybody really knows how to monitor. The way that we usually do, we have always a repeat biopsy at 1 year and then every 3 years. We use still the PSA density doubling time as a kind of trigger to have another additional information, whether it's repeat biopsies or MRI. I am not sure that we have any proof that what we do is better than others. And I'm not even sure that we know exactly how to manage it. For me, it's a really difficult question. So I'll switch to the last part of the talk, so we have a good half hour of cases, or end up a little bit earlier. Our main challenge, as you know, is to pinpoint the bad actors, correct? It's in those active surveillance, who are the bad actors? And this is especially true is that if you look at patients who underwent radical prostatectomy and had active surveillance criteria, there is a substantial amount, up to 25%, that will have higher disease or more advanced stage. So the argument all the time is, if you were to operate those patients, they would have much worse disease than you think. Still, nothing really happens. If you repeat the biopsies at 1 year, does that tell you that the patient is safe and that he will have no progression? The answer is no. Even in our series, when we repeat the biopsy, no cancer was found. There was less volume, so people didn't have those big Gleason 6, but we still were missing the small Gleason 7 and 8 later on. So even if you repeat at 1 year your biopsies, the biopsies all come negative, that's not a reason to stop the surveillance.
Are you asking MRI after repeating the biopsy? You making MRIs on biopsy?
So, yes, I mean, we do use MRI, but because we have so many of the protocols, and I'll talk about one of the trials where patients were randomized to MRI versus placebo. I would say that most of the patients are entered in protocols. So I have a little bit hard time telling you what we do outside of the protocol, because most of them will end up in protocols. I would tend to say that we have not an easy access to MRI in Canada. It's a public health system. And so we have to choose and pick our battles. And if we have no argument to ask for an MRI, we usually would skip. Here it is. MRI plays a role. David Margell, Nathan Lawrenchuk, a couple of years ago, clearly showed that in active surveillance patients where the PSA increases, you do an MRI, you're going to find what's called the PETs, the anterior tumors that are not visualized on ultrasound, that you can't palpate, that are PSA producing, and that would not be targeted with systematic biopsy. So by no means I'm trying to say that MRI does not help. MRI does help to find a couple of tumors anteriorly located that would have been missed. And that's typical. You see where the tumor, fairly high up, often peripheral zone biopsies would have missed it. But there is clearly, as we were discussing, an overestimation of the amount of clinically significant prostate cancer which are detected by MRI. Look at the number. Sensitivity, 94, 96, 73, 79. I think that a sensitivity around 80 to 85 is probably what is the truth, which means that you do an MRI, you will miss a lot. And in terms of specificity, it's even worse. You often will over-diagnose. And so I hear all the time, PIRAT's 4 or 5. It's cancer. I'm going to show you lots of cases where it's a Gleason 6, whether the glands are more packed, or I'm going to show some where the radiologist barely felt that there was a lesion. The patient was really adamant to get a biopsy and ended up with a Gleason 8. So that's the 20% of each of the columns where MRI does not play the role. It's a good test. It's better than PSA alone. It picks up the anterior tumors. It picks up tumors that can be treated focally. By no means I'm trying to say here that MRI does not play a role. in prostate cancer management in general, that it doesn't play a role in active surveillance and management. It absolutely does. But my impression from the own experience and what I hear is that we are too confident on the MRI. MRI is negative, oh, there's nothing. MRI is positive, it's something sinister. And that's where I disagree. And many people disagree. And if you look, and that's a systematic review recently done by the EAU guidelines, what you see is that the negative predictive value of MRI is around 80, some 60. So it's good, but it's not perfect. And the positive predictive value is also far from perfect. And that was the study of the accuracy of MRI and TRUS, and the PROMISE study. Again, the sensitivity was good, but still only 88%. It's better than the TRUS biopsy, no doubt. But it's far, in terms of specificity, of perfect, because this was only 45%. That means that a lot of people will have biopsies, and nothing will happen out of those biopsies. And you still will miss about 10 to 12%. This is why we usually have MRI targeted and systematic. We do it because, one, we have an active we have a focal therapy program where we still want to know whether these patients have a lot of lesion 6 all over the place, in addition to their lesion, but also because we don't fully trust our MRI-only targeted biopsies. So who does only MRI? So when you have a lesion, you only do the MRI biopsy, no systematic. MRI and systematic? Yeah, so still one person. We'll see. But the ASSIST trial was a trial that randomized patients to active surveillance with 2 12-core confirmatory, and the other one was the same, but within MR. And everybody was expecting that MR would be the winner, and classical criteria, active surveillance, favor risk, T1B and C, PSA less than 10, Gleason 6. I can't give you the paper because I know it's under review, so I won't say anything. But Lori presented the data, and oh my God, MRI was no better than the classical systematic biopsy. Randomized study. Food for thought. How can we pinpoint the bad actors? We have other ways to pinpoint the bad actors, and we have now, and Sigrid had a lot of new tests. I will quickly run through them. So some are the classical 4K, Phi, PCA-free test, multiparametric MRI, the germline variants, and the tissue-based, which are Decipher, Oncotype, and Polaris, among many others. The challenge is, as you know, when you have a tissue-based, is that it's a small sample. Prostate cancer is heterogeneous, and to what extent do you know that what you analyze is completely representative of the rest of the prostate? That's one of the challenges. The tests usually have been using RNA expression. The tumor is microdissected, the RNA is extracted, and the genes and the panel of genes will tease out those who are at low risk of progression versus who are at risk of having more aggressive disease. And I encourage you to read this absolutely beautiful review paper, Molecular Profiles of Prostate Cancer to Treat or Not to Treat, that really nicely summarizes the different actors that we can use. I've tried to summarize them here. The Polaris is a 46-gene RNA expression, and the low gene expression is associated with a low risk of mortality in patients who are active surveillance candidates. So it specifically addressed the active surveillance cohorts. The oncotype, prostate, a little bit like an oncotype for breast, also is a genomic test, also RNA, and that distinguishes patients with intermediate, low, or high-risk disease. And the Decipher, also an RNA test, also on paraffin tissue, 22 RNA biomarkers, more geared towards treatment with patients who need additional therapy, but still a pretty good test which tells you whether the disease is bad or not, because it's unlikely that someone who has a very aggressive tumor on the active surveillance will end up with a normal tumor on the radical prostatectomy. So do you guys use the tissue-based test when you manage your patients? Anybody? Okay. We do. It's costly. It's $4,500. So it's probably around 3,500, 4,000 euros. So by no means is it a cheap test. But I would challenge that in 2018, no woman on earth would be treated and managed for breast cancer without an oncotype. And do you know what the area under the curve for the aggressiveness of breast cancer is by oncotype? You are in Brussels, Stockholm, Madrid, Toronto, New York. A woman with breast cancer will have her tumor genotype with an oncotype or something else. And still, the area under the curve is 0.72. Only 0.72. Wrong in 28% of the cases. And I think that what we have as an issue, as a specialty, we always ask as urologists 100%. When we don't reach 100%, we can't match. The test is not good. But every woman is treated with a test which is 75% only. And so I think that most of those tests clearly have reached this range. And so I really predict that what is currently the scenario in the US, in New York for sure, in Toronto, and many other places where patient will come in, their tumor is a tumor not seen on MRI, characterized as active surveillance. People actually will have more and more their tumor sent, RNA extracted, and their genomic profile analyzed, with the acceptance that they can go on 20%. But I really think that's going to be the future. We can't continue to do what we've been doing.
I'm also thinking about the question that you asked earlier about the Gleason 3+4s, because I'm thinking that these tissue-based markers, there's a limited set of patients in whom measuring these tests would change your decision-making. If you have a Gleason 6, you're pretty sure you would put them on active surveillance. If it's a 4+3 or 7, 8, 9, 10, you're pretty sure you would treat them somehow. But if it's at the lower end of intermediate risk, then maybe the tissue markers could make your decision switch to one way or the other.
So to wrap up, typically, and I'll take the example of patients, typically when, and again, I'm talking and I'm putting the money issue on the side, and I agree it's very important. So by no means I'm trying to dismiss that money plays a role in our management. But most of the time when we have a patient who has a lesion, the lesion is targeted, it's a Gleason 6. It's more than 50%, so by the active surveillance, he's not an active surveillance criteria. Most of the time, we still will have a genomic classifier. If he's in the really low category group, and you're going to have at least 3 or 4 biopsies in this core, most of the time we would discuss, we would either focally ablate, if they want, or we would monitor. And that tells you that we are truly integrating nowadays the genomic, and especially when you have a Gleason 7, 3+4, a minimum of 4, characterize them, and then discuss. Finally, some of the proteomic profile, stay tuned, which also stratify patients into high scores or low scores. The calcrines, Sigrid, demonstrating that you can truly tease out non-aggressive from aggressive prostate cancer with the 4K test. Very often we would use this as well in active surveillance. If you have an active surveillance patient, you missed the tumor, or the test is very high, we are kind of anxious to have missed the wolf among the sheep. And a recent study, the Canary Pass, actually used the 4K and compared them to clinical parameters, published last year, a very, very good study, and where the accuracy for predicting reclassification was about 80%, so 78, not bad at all. So I have actually finished more or less on time so that we do have cases and we can go through them. Active surveillance is clearly an evolving strategy. Selecting the right patient and the right management is not easy. We struggle. I'm sure you struggle. And it is error-prone. I think it's safe to say that even if you use a little bit more liberal criteria, at 10 to 15 years, it is a safe approach, pending that a substantial amount, in between 30 to 50%, will end up being treated. But pinpointing the bad actors from the get-go is clearly still a challenge and difficult, and we need to stay tuned for the role of the genetic markers and the tissue-based. When you have a high-volume Gleason 6, probably it's a risk factor for coexistent higher-risk cancer, and genetic background, including race, has to be taken into account. And we'll see how things pan out in the future and how the next active surveillance course will be done in 1 or 2 years, whether my family will be a little bit more answers to the different questions. So that's about it for my part before we go to cases. Last questions?
When you make a real biopsy, how many calls do you make? And do you make more calls when you found at the place where you found the cancer before? And the second question: at what age do you stop biopsy? 70, 75? I don't know.
Two excellent questions. So the first question: we usually have a 14-core sampling, and we usually always go into the same area. And we're always astonished not to find tumor when we were sampled before. This is one of the most frustrating. I'm sure you have had the same experience. You biopsy, you re-biopsy, you're sure you find somewhere else for us. So that happens fairly often. It speaks to the fact that whatever you target, it's never completely accurate. That's the first question. The second question is, I don't know if you had the same experience, but I find more and more patients who do not want to undergo another set of biopsies. And they would do anything but to undergo biopsies. And so I would tend to say that I don't know to what extent, at what age do I stop doing? When do patients tell me, I don't want a biopsy anymore?
Of course, but if they are okay to accept the biopsy, what will you do?
The short answer is that I have absolutely no data to support anything. That's a short answer, except common sense. But I do really share the view, I miss your name, sir. I do share the view that we're going to see surprises in the next years, and that we stopped monitoring many of those patients in their 80s, and they will show up in their 90s or late 80s for the rest of treatment. I also don't have. The best, honestly, would be that we have an improved MRI or something which is image-based, plus a serum-based, and with an accuracy of 80 to 90%, and where everybody says, okay, we're fine, we don't need to have an intervention.
My question was quite similar about biopsies, but when do you recommend to switch from active surveillance to watchful waiting in which age? I mean, if you consider, for example, that you have access from look at the benefit of radical prostatectomy of patients beyond 65 years, and we have to ask ourselves if there is any time point when to stop active surveillance and then switch to watchful waiting.
Yes, but my problem is exactly the same as we discussed. All these studies above and under 65 were done many years ago. The patients have changed. Honestly, most of the time, when I discuss with an 82-year, 83-year-old gentleman, his first question is when to resume golfing. And I'm barely pushing it.
I see, but I mean, 65 years. Maybe do you stop at 75 years?
No, actually, I stopped honestly over 50 at 80. I would continue to do digital rectal because those people have some symptoms, they need some monitoring. So I think the GRE really would continue to pick up something early on and then to decide. Pure PSA, what age?
You should stop. Well,
Stop.
Screening and monitoring.
Well,
two different
when do
things.
you go from an active surveillance to a watchful waiting?
Yeah. Short answer, we don't know. We don't have the data when to transition or when to go over to active surveillance light. Yeah. So you're balancing life expectancy and then, like you said, when is curative treatment? When are you going to intervene as opposed to palliative care?
But even if we would state that the access on data is not present data, I mean, if we add additional 10 years, would it be appropriate to say, okay, you're 75 years now, your tumor is still a low-risk tumor, and stop now? It's a question, I don't know.
The fair question is that even with 20-year follow-up of some of those studies, basically in lesion 6 nearly nothing happens. So the short answer is that probably many of those patients were treated at one point when there was progression. And so you would have to model what would have happened if they were treated.
Right.
And what was the probable outcome, which I think probably would be difficult to do. So I personally think the issues will not be attendance. I think the issues will be beyond what we are following. We're going to have issues in patients who were 60, 65, actively surveilled, lost, and then will come in their late 80s, early 90s. I think that's where you're going to see some
Okay, so before we conclude this session, we have 3 cases to spark your interest and keep you awake this last half hour or so. The first case is about informed decision-making before prostate biopsy for early detection. So you are a urologist and you received this referral from Dr. Primary Care. So dear Dr. Urology, Mr. Patient is a 79-year-old healthy gentleman with an elevated PSA. What should we do now, you think? Can you please take a look? Does he need a prostate biopsy maybe? I'm sure you see these referrals all the time for an elevated PSA. And this is the case that you were alluding to earlier about the older gentleman who's 79. So for whatever reason, someone has measured his PSA, and now the primary care is stuck with it. He doesn't know what to do, and so he refers him to you. What do you want to know? What do you want to know more about this patient or this case? What is his PSA level? So he has had his PSA measured multiple times in the past few years, and recently he's been repeatedly measured, and you can see in the, every 2-3 months or so. And it's been from around 4 to now it's about around 6 or so. Did this information help you? No. What do you do now? Volume, exam. Should we talk to the patient, maybe? What do we ask?
How does he pee? How does he think about it?
How does he think about it? And what do you mean when you say that?
Is he stressed? Did his neighbor die from a prostate cancer 2 weeks ago?
Exactly. Usually that's what happens. Everyone has a neighbor or a friend. They sit in the sauna, they talk about the PSA levels, and and I had cancer, and they're stressed. So he's very anxious about this increasing PSA, and that's why he comes, and he wants more testing, and he wants to know. What else do you want to know? How do you picture this man in front of you? We know he's healthy. What does he look like? What does he do? Is he active? What do you want to know?
Prostate enlargement.
Prostate enlargement, yes. We'll find that out. Symptoms. Does he play golf? I don't know. We might want to know. Yes.
I would just want to see the patient,
Yes.
look at him, talk to him,
Yep.
and don't look at the birthday.
Exactly.
And do the same for me in my brain. How would I measure? How would I expect how old he is? And it's a good marker.
Yeah.
But what is he doing with his life and going on? Is he working?
Exactly.
There are some old people who really
Excellent. Yes.
I think the point is, the first thing is not that the information
Yep.
of the age of the patient is the last stone which should make a decision.
Exactly. Chronological and biological age can be very different. So when we just see, age and the value, we might see one patient. But then if you see all of this, you might see a different patient. So he has AFib. It's a comorbidity, but it's nothing, major severe. He doesn't have any family history. He's a marathon runner. His parents lived to the 90s. He's sexually active. He has a partner. He has mild LUTs, as most men do this age, and he is worried. Do you see a different picture in front of you now? Different patient, right? So this puts it in a different context. So if you just know the age and the PSA level, you would have said, oh, why did you measure it in the first place? But now there might be, a rationale for why he might have had the PSA measured. So now what do we do? Exam. Okay. So you do the DRE, and it's benign. He has a slightly enlarged prostate. Are you surprised? Okay, so we have some more information. What can we do now? What should we do? Should we send him home and say, go fishing? We have that difficult conversation that we don't know how to have. Some other blood marker? Should we send him to the bathroom to leave a urine test? Should we do an ultrasound, an MRI? Should we use a risk calculator? MRI?
I will do an ultrasound.
Ultrasound? Control PSA again. So we do that, and it's slightly, it's around 5, 6.
He's an anxious guy, so
He's anxious.
he's going to another neurologist.
Is the urologist also anxious, maybe? Both of them are anxious. You want to do something. Okay, so we do an ultrasound, as someone suggested. So his volume is 68 cc with central calcifications and central adenomas. Did this help you? No. So we have PSAs elevated, it's slightly enlarged. What do we do now?
How much is his PSA secret?
It's around 6.
Is so because this is a great question.
Yeah.
For me, someone who is 79 with a PSA of 6 has an absolutely normal PSA. 6.5 based on the fact that with age the patient has an enlarged prostate. So I have to admit that patient no symptoms, normal DRE, PSA which is less than the age range, and with sound calcification, leave him alone.
Leave him. You would send him home to his White House. So more markers, more blood tests, the free PSA. Anyone want to measure something else? Some of the other markers we talked about, maybe? Do you want to plug in the numbers in the computer? You did it, and?
2.9% were relevant
2.9%. Okay, let's see if my thing said the same thing. Are we using the same risk calculator? Different one. So this is also interesting. ERCP. Okay, that's very interesting. So then you can see how different risk calculators show you different results.
By no means I'm trying to throw you under the bus,
Yes.
although I'm going to do it. I'm joking. I think that because we compared the ERSPC risk calculator with PCBT in our Toronto series, PCBT was terrible.
Oh.
Really terrible. And I actually, I like Swiss wine, so I probably would go for ERSPC Swiss. But I clearly would go for ERSPC. And my gut feeling would be that the high risk chance will be closer to probably 4 or 5%.
4 or 5% than 14. Yeah.
Well,
That's interesting, right? So, I mean, the patient could have gone to the website and plugged in his numbers himself here. So,
that's right. The guy is in New York, you will go in onto the PC.
yeah. So you use the age and region. That's very interesting. So we have two risk calculators showing slightly different results. So now we are even more confused. Yeah. Exactly. So now we're even more confused. Yeah. Okay, so two different risk calculators, PSA, some slightly elevated. So someone said free to total PSA, or we can run the 4K score. So we do that, and it shows a 40% risk of high-grade disease. So that's even higher than the risk calculators. So is there something there? Can he still have a prostate tumor somewhere in his prostate?
But this is all psychological now.
He's even more anxious now.
Then you can't let him go home.
No.
You can't just do nothing.
So the urologist is becoming more anxious and the patient is more anxious.
I mean, PSA is the prostate-specific antigen. Shouldn't be the patient's stress amplifier or the physician's stress amplifier, correct?
Right.
So,
But it's a slippery slope because once you start, that now the snowball is rolling, and what do we do now? So this man, he's like, okay, I'll pay for the next test. Okay, so we have another test that we can do. So we do this newer type, Select MDX. And that one says he has a very low likelihood of detecting Gleason 7. The negative predictive value is 98%. So now we have two different tests saying completely opposite result. And this is a true case, by the way. So 4K score very high, the Select very low. The risk calculator we don't know.
can that really be annoying?
Yes, be annoying.
I have a major problem with the 4K test in the sense that the 4K merges the intact with the HK2, which has 80% homology with HK3 PSA and the free. You have a guy who has an enlarged prostate of 68 gram with some calcification, so by definition there has been inflammation. We perfectly know that just by the age, the guy has 75% chance of having prostate cancer in his prostate. I don't need to know anything. I know that he has 75%. No one cares. The only thing you don't want to miss the 8, 9, and 10 for this guy. That's the only thing you look at. Your 4K test, by definition, because everything is calcine related, I don't get if you truly have an increased and you have some inflammation, how it will not drive the things towards an increased risk.
I wonder the same too.
I'm told that it doesn't, that blah, blah, blah.
Yeah.
But I still struggle. And if I have to buy something, first of all, I have to admit I would not have asked for the test. I would have personally said, go home and go fishing or golfing. That's personal.
Yeah.
And I'd rather take the MDX test, which is completely unrelated to the calcrines, than a calcrine-related test in an increased case.
That's interesting, yeah. And I think we need more studies in the elderly about the 4K, because age is also part of the score, so that might also drive it up a little bit. Okay, so two conflict. Do we have something else that we can do in our toolbox? Now we end up in the MRI. And There is something there. He has a tumor, 1.1 centimeter. You can see it here, and Pirates 4. So there actually was something there.
Now you will have to biopsy.
Now you'll have to biopsy him.
Yeah, he's anxious.
He's anxious, and there might be something there. Pirates 4. So it's a pretty high likelihood that there might be high-grade disease there, right? So in summary, 79-year-old man, conflicting results, Pirates 4, patient's anxious, you're anxious, and what do you do? And what do you tell doctor of primary care?
So who would have biopsied this patient?
I would have a single biopsy just to exclude needle 9.
Okay.
Because this guy goes home, he will be reassured. What you did to him, he's panicked. I have something, he goes up to the internet, I have cancer, they don't do nothing, he switches off, he's anxious. And he will go to the next urologist and he will end up with a biopsy. The only thing you can do is do a biopsy and not treat.
That's fair enough.
And he also has the AFib. He might be on the, what's it called, the little heart tablet.
So fair enough, and I completely appreciate your point. I think it's a very valid point. The downside is that if he ends up, Pirates 4 will be 60%, predicted, not 100%. He has an enlarged prostate with an increased risk of complication, because size is truly one of the determinant of complication after biopsy. And I had a patient like that. It's not a joke. And the reason we did the biopsy because the person is an African Canadian, so I usually take zero risk in people with African background given the key risk. He ended up, and it's close to that, he was 82, a professor. He ended up in the intensive care, had bleeding, had a sepsis, and his biopsy was negative.
Yeah, but why do you do all those tests that are positive MRI and you don't do nothing?
No, I hear you. I hear. Here, it's a completely different story where the patient comes, great shape, then some family history, we do the MRI, he's on board, he wants to. So we're exactly the same thing. And I think no one would argue about what you do, and you hear what we've done because we're on the same page. But I was simply addressing the fact that we tend to underestimate that for this gentleman, we're going to have to, shit will happen sometimes. And I think we need to be careful. That's truly what my message.
You know, but it's a great, perfectly valid point. You know, you should only do something if it changes your decision making. Order more tests. So the question is, where should you have stopped, or shouldn't you have stopped? I mean, that's the question.
Let's say we have the same case, and you are a tertiary center, and you receive him after the biopsy. And let's say he has intermediate risk cancer, let's say 15 years old of life